Good morning, everyone. I am Dr. Apurva Oja, DNB trainee from Dinanath Mangeshkar Hospital, Pune. Here I am presenting a case of an intermediate uveitis in a pediatric patient. A 7-year-old female child presented to the OPD with chief complaints of firecracker injury in the right eye, with decreased vision and change in the shape of the pupil, and there was redness. And it was sudden in onset, acute in course, and it was on limited period. You can see it in the right eye. In right eye, on examination, vision was counting finger 1 meter and less than 36. Lids and conjunctiva was normal, cornea was clear, and on pupils it was irregular, and posterior synechia was present at 6 o'clock and 11 o'clock. Lens shows complicated cataract. On applanation tonality, pressures were normal, and on dilated fundus examination, grade 4 vitreous haze was present. And left eye, all the findings were normal. Here you can see in the image there is a right eye vitritis present. Left eye were normal. We have advised chest X-ray skull AP view to rule out any foreign body, and she was started on topical steroids along with cycloplegics. On follow-up, there was no foreign body in the X-ray. In right eye, there was a vitreous grade reduced to grade 3, and USG scan was done to rule out the retinal detachment or any other pathologies. On clinical examination, right eye shows long-standing ocular inflammation having vitritis, posterior synechia, and peripheral patch of retinitis. This is the USG image showing the vitreous exudates. On ACT, there is a right eye retinal thickening, and left eye, all the findings were normal. Ocular toxoplasmosis and toxocarisis was suspected and thus referred to infectious disease specialist. All the investigations were done, like toxoplasma IgG, IgM, and HIV ELISA. All the tests were negative. Montauk's test was negative. After the vitritis clear, we could see a large snowball in the vitreous, but no retrochoroidal gonoma or vasculitis. In the meantime, left eye showed the snowball. So we revised the initial diagnosis from toxoplasmosis to idiopathic intermediate uveitis. In the course of disease, here you can see there is a developing ERM also. Epiretinal membrane. Vision deteriorated further in the right eye. We have started her on Visalon, but as we taper, there was a recurrence of the disease. After the 6 weeks, vision was improved significantly to 6 by 13 and 18 in the right eye. So the diagnosis was both eye regressed vitritis with retina on, and there was no cystoid macular edema. She was in follow-up with us by having cataract in the right eye. Pediatric hematologist opinion was taken to start her on methotrexate, but recurrence was still present. So along with methotrexate, we have increased the dose of steroids also. As we used to step down the steroid, there was increase in the recurrence of the disease. So we have shifted her on adalimumab, and the vision improved to 6 by 24 and 10, and the left eye 6 by 9 and 6. She is actually a B51 positive patient but does not have any oral or genital ulcer. Now the patient has been shifted to tocilizumab, and she has received tocilizumab 10 dose, and vision is 6 by 18 and 6, and in the left eye 6 by 9 and 6. And the patient is having idiopathic intermediate uveitis. For the discussion part for the etiology in the infectious, we have toxoplasmosis and toxocarisis as the leading in pediatric cases. In case of non-infectious, JIA, and in case of masquerade syndrome, leukemia leads the etiology. For the treatment part, I would like to discuss local steroids. We have used local steroids, or we can use intravitreal steroids. We can use methotrexate has been approved for the use in intermediate uveitis. We can also give intravenous steroid and oral steroids to the pediatric patient, but it can lead to side effects like Cushing features and growth retardation. So we cannot give them for long term. So we have shifted to biologics. Anti-mucin necrosis agent, infliximab, abatacept, tocilizumab, and rituximab can be used, but in the under the cover of a pediatric rheumatologist only. The current approach is to treat the acute inflammation with rapid establishment of the steroid-sparing medications. Adalimumab has an FDA approved for the treatment of intermediate uveitis. Potential adverse effects such as increased risk of opportunistic infection, malignancy should be carefully weighed against the benefits of the biologic therapy in the particular age group who has long life expectancy. Vitrectomy is an option for diagnostic as well as therapeutic purpose, but only in special cases like epiretinal membrane or media clearance, or in the case of the epiretinal membrane and macular holes. Thank you. These are my references. Thank you.
Which local steroid did you use in this case?
We haven't used any local intravitreal steroids.
That's precisely my question. Why you did not use any local steroids in this case? No PST, no Ozurdex. Why?
Invasive. Patient was not willing for any invasive procedures.
See, adalimumab is much more invasive when you talk about the drug. I hope you must have read the inserts of both adalimumab and tocilizumab.
She was taking subcutaneous.
patient has to give a very long consent for this. And
Every
there's
2 weeks she was taking adalimumab.
and there's a definite risk of B cell mediated malignancies when we give these drugs. While
TNF
we cannot
alpha.
treat it with a peribulbous steroid or a injection.
Uh, we have given them option, but they were not willing. So, and
See,
for adalimumab, this.
at the end of the case, it's a Behçet's which had trauma just like that. So that is what you're dealing with. Your baseline diagnosis should be Behçet's. So for management of Behçet's, switching on to adalimumab at 7 years of age, you'll have to maintain
7 years. It was a long course of disease. We shifted around 9
years.
to
9 to 21 you have to keep the
Ah.
patient on adali. So the cost and the invasiveness of the disease treatment is a bit more compared to what the disease could have been
She's
managed.
on tocilizumab,
You
yes,
did
sir.
not mention azathioprine as one of the choice agents. In fact, azathioprine is a better tolerated drug in this age group when you are looking for long-term results.
Actually, drug was selected as per pediatric rheumatologist. We have suggested them. We have referred this patient to them. We need a rheumatologist opinion because she's a pediatric patient. We can't means do on our own.
Okay.
So it was as per pediatric rheumatologist.
That's all.
Thank you.